Dear colleagues, welcome to our monthly dialogue. This dialogue is really a very appealing, interesting dialogue with one of the protagonists of the history of cardiovascular medicine. When you will hear his name, you will realize that tonight we have an important protagonist. What is done for cardiology really changed the history of cardiovascular medicine. It's a great privilege for me to introduce Professor Ulrich Sigwart, the inventor of stents, and the title of this dialogue is Dialogue with Professor Sigwart on Past, Present, and Future of Stents. It's my pleasure to introduce Colin Berry, Executive Editor of the European Journal. I will host Ulrich with Colin. We will ask him questions. The goal of dialogues, as you know by now, is not only to know about science, the science produced by our important guest, but we want also to unveil their human side, which is a source of inspiration in particular for our younger colleagues. Colin, please, let's start introducing Professor Sigwart, please.
Yes, thank you, Filippo. I would like to say at this point it's an enormous privilege to participate in our dialogue session this afternoon, in particular with one of the true leaders in the field of interventional cardiology, Professor Ulrich Sigwart. And being an interventional cardiologist myself and having been in the cath lab today, this really is a special moment. And I'm delighted to take forward our dialogues today. So Professor Sigwart, the warmest welcome.
Thank you very much.
And also I'd like to extend this welcome to those participants in our dialogue today. And Filippo, I'll now continue to give a biographical overview for Professor Sigwart. Professor Sigwart is a world-renowned cardiologist, known for his pioneering role in the conception and clinical use of vascular stents. German-born, Dr. Sigwart first received his medical training at the University of Freiburg and the University of Basel, where Professor Sigwart is today, in Basel. He graduated from the University of Münster, earning an MD in 1967. He then completed a Doctor of Science in Medicine at the University of Freiburg that same year, followed by a Venia Legendi in Medicine at the University of Düsseldorf in 1978. After finishing an internship at the Community Hospital of Lörrach, which is close to Basel, Dr. Sigwart traveled to the United States to complete his residency training at Framingham Union Hospital. Of course, that's in the famous town of Framingham, close to Boston, and then to the Boston VA Hospital, as well as a fellowship in cardiology at the Baylor College of Medicine in Houston. And based on our preliminary discussions, I'd like to highlight that family members of Professor Sigwart were born in the United States. His daughter was born in Boston and his son was born in Houston, as is often the case for colleagues who undertake fellowships abroad. Thereafter, after training in 1973, Dr. Sigwart took on the role of Chief of Catheterization Laboratory at the Gollwitzer-Meyer Institute, which later became the Heart Center North Rhine-Westphalia in Bad Oeynhausen, Germany. There he set up an interventional cardiology program. 6 years later, Professor Sigwart was named Chief of Invasive Cardiology at the Lausanne University Hospital in Switzerland, where he started the fundamental work on vascular stenting. During this time, many colleagues traveled to Lausanne to observe and learn from Dr. Sigwart's techniques. Remaining in this role for 10 years, from 1979 to 1989, Thereafter, he then moved to London, England, to work as the Director of Invasive Cardiology at the Royal Brompton Hospital, where he worked for 12 years, before then ultimately returning to Switzerland in 2001 to serve as Chair of Cardiology at the University of Geneva. Recognized then as an emeritus professor, Dr. Sigwart retired from his post as Chief of Cardiology in 2006. Just to provide a little bit more detail on some of the seminal advances led by Professor Sigwart during his career. In 1987, Dr. Sigwart authored a landmark paper that described the first clinical use of coronary stents to prevent occlusion and restenosis, these being the most common complications following transluminal balloon angioplasty, which limited the effect and benefit of this technique. The article was titled Intravascular Stents to Prevent Occlusion and Restenosis After Transluminal Angioplasty. Dr. Sigwart not only conceived and developed of endoluminal stenting to treat coronary and extracoronary arterial disease by providing the stent developments as a viable and safe alternative both to balloon angioplasty, but also to challenge the paradigm of coronary artery bypass surgery. Dr. Sigwart also invented the non-surgical technique known as alcohol septal ablation, or the Sigwart procedure, a percutaneous technique to reduce abnormal enlargement of the ventricular septum that is well established now for hypertrophic cardiomyopathy. In 1994, Dr. Sigwart treated the first patients in London at the Brompton Hospital with this now well-established technique, thereby enabling some patients to avoid surgical myomectomy for this condition. Just to give you further perspectives on Professor Sigwart's life's achievements, he is the founder of the Jonas Foundation alongside his wife, Christine Sigwart Sartorius. Dr. Sigwart formed this humanitarian organization to help young people find new hope and perspective in life, fight social occlusion and violence, and promote cross-cultural dialogue through the arts. He also chaired the Swiss Cultural Fund in the United Kingdom during his time there, and served on the editorial board of several journals, including the Journal of American College of Cardiology. Dr. Sigwart also co-edited and authored several handbooks and contributed to more than 700 journal article publications. I'd like to conclude now by just highlighting some of the distinguished achievements and recognitions in his career. Dr. Sigwart has numerous awards. In addition to receiving an honorary doctorate degree from the University of Lausanne in 1999, he also received a European Society of Cardiology medal, the Grüntzig Award in 1996 and in 2006, the Forsman Prize in 2001, the King Faisal International Prize for Medicine in 2004, and the Pulitzer Prize from the European Academy of Sciences and Arts in 2007. Finally, the American College of Cardiology has awarded Dr. Sigwart the Masarai Florio Award and the Paul Dudley White Award and the Distinguished Scientist Award. Dr. Sigwart, it is a true pleasure and privilege to be with you today, and we would like to now continue, perhaps more informally, with some questions and a discussion, which will be led by myself and Professor Crea. Therefore, and also just to highlight that we will welcome the engagement of our colleagues and participants on the call. Please do feel free to type in questions into the notepad function on Zoom. We'll be welcome to pick up on these questions and introduce them into our forthcoming dialogue. We're delighted that you've all joined us today. So, Filippo, if I may, I'll pose the first couple of questions and then pass over to you.
Please, Colin, let's continue with your questions.
Great, thank you. May I first ask, and if I may, Ulrich, was cardiology your first and lifetime choice? Did you always intend as a growing young boy turning adult, was cardiology or medicine always your intention, or did you have other thoughts?
Thank you for asking. As a matter of fact, I was aiming to be a veterinarian surgeon when I was a boy, and then I hesitated to become an airline pilot before studying medicine. My sister persuaded me, so to speak, who was studying medicine, persuaded me to go into human medicine, and I do not regret it.
So it was your sister who, if I understood well, your sister positively encouraged you to medicine?
Indeed, yes.
And did your sister have a background in medicine?
She studied medicine as well.
Wonderful.
I think she was the turning point for me to go into medicine, to human medicine.
May I probe further? Was she your older sister or your younger sister?
Older sister.
Yes.
Older sister.
Yes. So she had set a path and that encouraged you in this direction.
Indeed, yes.
Okay,
It is a wise family.
Thank you. Thank you. Yes. My father was a chemist, and my sister went into medicine and married also a doctor. And now I have a grandchild who is going into medicine.
Ah, okay. Training in Switzerland?
In Switzerland, indeed, yes.
And did your sister work in Switzerland also?
No, no. Unfortunately, my sister died early from a malignant disease.
Yes. Okay. Well, let's continue. What attracted you to cardiology? You went into medicine, but of course then subspecialized into cardiology and then, of course, interventional cardiology. So what enticed you in that direction?
Well, as a medical student, I was fascinated by cardiology. It was the movement, I think, the movement of the circulation, the action of the heart, and the hemodynamics that made me go into cardiology. I was absolutely fascinated by the circulation.
So you mentioned earlier an interest in veterinary medicine, but also being an airline pilot. And what I recognize in these two specialties, along with interventional cardiology, is the application of clinical acumen in real time, the application of practical skills, manual dexterity. Would you concur with me in that regard?
You have a point there, yes. I started flying at the age of 15 and always was fascinated by flying. But the second fascination was the circulation.
Yes. Very interesting. Okay, so we've summarized your professional journey in cardiology and interventional cardiology. But let me ask about a peer, a contemporary of yours, who was also had a seminal role in the development of interventional cardiology, Andreas Grüntzig. You must have met him and known him. We would love to learn your experiences in meeting Andreas Grüntzig.
Yes, indeed. Andreas worked at the same time in Zurich as I started my cardiology career in Zurich with Willy Ruteshauser, who was my boss. And then while I was working in Bad Oeynhausen in Germany, I went to Rotterdam to a computers in cardiology meeting and met Willy Ruteshauser there, who took me aside and said, did you know that Andreas implanted the first stent into the coronary system last week? And of course, I didn't know it. It was top secret. So, but this made me travel to Zurich. We had lunch together, Andreas and I, and he gave me 3 balloons and 2 guiding catheters, which allowed me to make the first 6 coronary angioplasties in Bad Oeynhausen. Bad Oeynhausen didn't have cardiac surgery, so I had a meeting with the leader of a helicopter department of the Bundeswehr, the military service, who stood ready to carry a patient, if needed, from Bad Oeynhausen to Hanover, just in case of an emergency. This was the pioneering time, and I published the paper of the first 6 patients in the German medical cardiology journal the same year. But it was, of course, it was not a good basis for continuing in a place which had no cardiac surgery. So I took the offer to go to Lausanne and take over interventional cardiology at the University of Lausanne.
Very interesting. And so you and Andreas Grüntzig worked. Clearly there was synergy. It's encouraging to hear that at your first meeting, he was literally giving you the materials to facilitate your own practice, that rather than a sense of competition, that rather there was collaboration.
Yes, yes, indeed. And later on, when I initiated the first meeting in Lausanne, where we produced to see the results of our stent experience, Andreas was agreed to come to, he was at the time in Atlanta, he was working in Atlanta already, but he agreed to come to Zurich to give a talk, and unfortunately he died just before plane accident.
Yes, and what a great loss to our community. Okay, moving on. You led at the cutting edge of interventional cardiology in relation to coronary stent development. You were involved in the very first procedures. You were dealing with unknowns and uncertainties and challenging circumstances. When did you get a sense, or perhaps you could describe how you began to realize the significance of coronary stent implantation? You must have been working in challenging circumstances when there must have been times when you might have thought this is not going to progress. You may have had ethical boards or the institution saying this is not accept. You know, the challenges when you're at the cutting edge. When can you share with us how your experience or your realization that this was a transformative technology?
Yes, as you know, surgeons were always on standby while we did angioplasty at that time. And one particular case intrigued me enormously. That was a patient who came all the way from the United States to have a coronary angioplasty in Lausanne. And it was a very tight circumflex stenosis, which I dilated, no problem, easy case. I took the balloon down, removed the catheter, and the artery is closed. I'll never forget this moment. And I asked the surgeon to operate on the patient, and I felt very, very bad about this, because this patient took the pains in taking a plane from, I don't know where it was, Washington or wherever, to come to Switzerland to have this done and ended up in surgery. And I said, we have to have a support. And my vision was to look at tunnels. In Switzerland, there are plenty of tunnels, of course, trained tunnels.
Yes.
And they always have a reinforcement from the support from the inside, which keeps them open. And I said to myself, we must have some hardware to put in there to keep arteries open and to prevent this from happening.
Yes.
And one of my colleagues at the University of Lausanne, he was an experimental surgeon, gave me the address of a businessman who was working in the near Lausanne. Hans Wallstein was his name. He invented some tools for newspaper printing of newspapers and this kind of thing. And I contacted him, and we sat down to initiate the first geometry of a vascular stent with the help of a young engineer, Christian Ambert was his name. And we did, after months and weeks of production and essays and trials in sort of artificial circulations, we implanted the first stents in Lausanne. But I have to tell you how it worked, because Hans Wallstein, the one who finally launched this as a business, was impatient, and the ethics committee in Lausanne had great difficulties in accepting such intervention. It's something entirely new, and they felt not completely competent.
Yes.
To agree to that. It took weeks. And Hans Wallstein was impatient. He wanted to make some money, and took the first stents to Toulouse to ask somebody who didn't have an ethics committee at the University of Toulouse, and he implanted the first stent Monday morning in a patient without telling me. And I was, of course, very cross. And but
yes,
this was the first human stent. I shortly thereafter I got the permission to do it in Lausanne as well.
So these are unique, pivotal insights for our participants, our audience today, that only you are in a position to share. And I'm now going to pass over to Filippo, who'll continue our dialogue. Thank you.
Thank you.
Well, Ulrich, first for these insights into the development of stents. And I think it is a very interesting story, which stemmed from this American patient who had the artery blocked because of a traditional balloon procedure. And this sense of frustration you experience triggered your curiosity and your interest in new ways to approach the problem. And I think that this is, for young colleagues, extremely important. In life, it happens to have frustrations and difficult moments and hurdles we cannot overcome, but it is at the time of difficult moment that if you have determination and resilience, it is in front of this difficult moment that you can really produce something very innovative. So your history, I think, is very instructive. And I have a first immediate question. What was the anti-thrombotic regimen in this first patient you submitted to stent implantation? Was anticoagulation at that time, right?
Yes, yes. Well, we gave aspirin as that was the routine treatment for angioplasty at the time, aspirin. and of course heparin during the procedure, and then we were hoping to get away with that. And that was, of course, in stents, we gave also disopyramide, aspirin and disopyramide, and kept for a few days, we kept the patient on heparin.
But there was a phase where anticoagulation with warfarin was used in after stent implantation.
Indeed, yes, indeed. Warfarin as an immediate treatment starting immediately after the implantation.
And then trials clearly showed that double antiaggregation was better than anticoagulant treatment. I think that was a major step forward in the success of stenting.
Of course, yes, of course. And of course, this is a long story, as you know, and for the time being, we have treatments that is no longer permanent treatment for patients with stents, but everything is being discontinued relatively early.
Now, stenting was a major revolution coming from Europe. We know that many discoveries in cardiology come from Europe, and stent, thanks to you, to your efforts, has been something which started in Europe. But what about the acceptance of stenting? Was quicker in US or in Europe? Which continent reacted more quickly and efficiently to this new discovery?
Well, the Americans were extremely interested in this, of course. And I remember giving a talk in I think it was in July, just after the first stents were implanted in Europe. I gave a talk in Atlanta, and somebody, after my talk, somebody by the name of Richard Schatz came and shook my hands afterwards and congratulated me and said, look at this. He gave me a small stent, a balloon expandable stent. I had started with a self-expanding stent, as you know. He gave me a balloon expandable stent, which was about 2 centimeters long, and it was the Palmar stent, which was extremely rigid. And I looked at him and said, this wouldn't work in coronary arteries because our coronary arteries are curved, and this would it just would be unphysiological to implant this in coronary stents. And so he went home and cut it in half and bridged it over with a small 1 millimeter long bridge and called it the Palmar's Schatz stent. And this was a balloon expandable stent which took over fairly easily in the United States. But this was long before the multi-link stent came up and other stents that are more physiological.
So the acceptance of stenting was overall quicker in US than in Europe. This is your feeling?
I'm sorry, I didn't get the whole.
Yeah, I mean the acceptance of this new technique, stenting, the acceptance and the implementation was quicker in Europe or in US?
Oh no, it was quicker in Europe. It was quicker in Europe. US, the FDA is very complicated, of course, and it took quite a while until stents were allowed for implantation in the United States.
While the transition from self-expandable stents to balloon expandable stents, as you said before, was rather quick. I mean, it became quickly clear that balloon expandable stents offered advantages over self-expandable.
Indeed. You're perfectly right, yes. The self-expanding stent had some problems. First of all, there was a wire crossing, which of course reduced the lumen slightly and created turbulence. Every millimeter or so implemented a wire crossing. Secondly, the implantation technique was rather complicated, and not everyone could do it, because when you release the self-expanding stent inside the coronary artery, it was moving, and you had to predict the landing space where exactly the position of the stent would be, and this required quite a bit of experience. You had to constantly readjust the position of the catheter while it was being deployed, and that was not for everyone. It was, in my opinion, it was too complicated. And also the restenosis rate was not as low as we hoped for. This is why I was involved in the creation of the multi-link stent with ACS at the moment, at the time in California, which took over like an explosion around the world.
Ulrich, in 1996, you gave a memorable Grüntzig lecture, and the title was Stents, a Mechanical Solution for a Biological Problem. Do you still believe this is the case?
Yes, I think so. It's not the solution for the biological problem, but it is at the moment, I think, something we cannot live without. It's something we have to have. Stents must be on our shelves to allow angioplasty to take place.
Thank you, Ulrich. Colin, fascinating story. I'm sure we have other questions.
Good, great. I was on mute. I couldn't release the mute. So yes, I do. Thank you. It's been really interesting to follow this dialogue. So let's continue. Ulrich, my questions now are forward-looking. At the present time, we are in a stage of transition. New technologies are constantly emerging, bioresorbable scaffolds, perhaps not with the penetrance that had been anticipated. Now, drug-eluting balloons are emerging. The stent designs are constantly evolving. I'm interested in your thoughts on where we might be in the future. You've indicated the importance of coronary stents. Do you think bioresorbable scaffolds or drug-eluting balloons or perhaps some other technology, and where might we be in 5 or 10 years' time?
Well, I'm not a prophet, of course, but I suppose that some sort of scaffold will remain in interventional technology for the next 10 years at least.
Yeah.
It would, bioresorbable stents are a very smart idea if they can be made strong enough to keep the artery open. Balloons only, like Antonio Colombo said, just balloon
be inadequate.
Coated. I'm sorry.
I think you're suggesting the drug-eluting balloon ultimately may prove inadequate.
I think it's lovely, but it's not enough for everything. It wouldn't allow us to do angioplasty in all cases, because oftentimes the artery literally falls apart when we deflate the balloon.
Yes.
We have to have some structural support. There is no.
Yes. And actually, we've seen this issue in the most recent large multi-center randomized trial of drug-eluting balloons compared to stenting, where the results were not as expected by the let's say the research community, and the stent results proved superior think it was the Favor 3 trial, if I remember well. And therefore, I think this is an area of ongoing research.
Indeed, yes. But I think it's common sense that in a fragile artery, which is likely to literally fall apart, the walls fall apart. It's mandatory to have some support, some structural support inside when you treat this.
I think it will be interesting on how the technologies evolve. We benefit by having the interest of industry or industrial stakeholders who are constantly seeking to improve. And it will be interesting to see where we are in 5 to 10 years and whether bioresorbable scaffolds make a return with penetrance, whether there may be some specific indications where a drug-eluting balloon may be sufficient. But my own view, I agree with you that the stent has got an essential role in preventing early reocclusion, acute closure, which was very much the issue for you and your colleagues as you worked in balloon angioplasty, and the stent was a solution for that problem.
Yes, yeah. Of course, I'm not a prophet, but I think it's common sense to support the artery from the inside once you work on it.
So, medical therapy in recent years has gained traction as a primary treatment for patients with obstructive coronary disease. Of course, the indication for coronary intervention is determined by a number of factors, symptoms in particular. But let me give you a clinical scenario. It's designed to be thought-provoking and be of interest to our participants. But this is a scenario that does occur in clinical practice. A patient who is stable, who may have had angina, but with medical therapy, their symptoms have been controlled. So they have a stable clinical status. They have preventative therapy with aspirin and statin, but perhaps they've received a beta blocker and they're now asymptomatic. But as part of the standard care evaluation, they have had a coronary angiogram, and the angiogram reveals proximal severe stenosis of the left anterior descending artery. There may be no right answer to this question, but what would be your perspectives for the management of this patient?
You are posing a very tough question.
Yes, my apologies.
very, very tough question. But personally, I would probably go ahead and do something.
Okay.
Like this. Especially if the patient has a positive electrocardiogram and has a change ischemia.
Inducible ischemia.
Exercise test.
Yes.
I would then say his threshold, his pain threshold is probably fairly high, and
yes,
physiological implications of this are serious. So I would probably go ahead and do something about it.
Yeah. Thank you. Thank you for.
Am I the only one?
No, I think if the patient is truly asymptomatic, there's probably a growing proportion of cardiologists who would not perform PCI. But I think probably the majority would still perform PCI, especially in the context of inducible ischemia.
Yes,
because this is a
patient of yours have a coronary angiogram in the first place.
Because they had symptoms, and the angiogram was scheduled as part of the management plan.
So he was symptomatic anyway.
He was, yes, initially symptomatic, but the symptoms, the angiogram is, in my practice, it's not the first test that's performed. You risk factor evaluation, medication may be started, response to nitrolingo spray, but with an abnormal exercise test or other functional non-invasive evaluation, and there's inducible ischemia, we would undertake invasive coronary angiography. I think most clinicians would. But it's also a scenario that is not abstruse. It is a scenario that does occur. And in the end, there may be no right answer. But it's just interesting to hear your perspectives. I think many clinicians would proceed exactly as you have described.
Including yourself?
Yeah, I think so. If it was a tight proximal LED stenosis, I would not leave the patient in the cath lab without performing PCI.
How about in Italy?
Well, in Italy, the attitude is similar, although I think it's aggressive, as you are saying. I mean, better to go for stenting rather than just leaving medical therapy. But I think that this is a moving target. Even guidelines in Europe and US do not agree on this point. And an important element, I think, is the transition from invasive coronary angiography to non-invasive coronary angiography. Because if the patient goes for invasive cardiology, once we are there, well, the temptation is too strong to go for stenting because you are there.
Indeed.
But this proximal LED stenosis is observed with non-invasive coronary angiography in a patient with stable, good effort, symptoms well controlled, stress ischemia not so large. I mean, if everything is stable and the patient is asymptomatic and the amount of ischemia is not so large at non-invasive stressing, I think that more and more, perhaps the temptation based on non-invasive coronary angiography, as you are not there ready to implant the stenting, perhaps more and more the transition will be towards a conservative approach. Also because we are learning that ischemia doesn't predict outcomes. What predicts outcomes is the amount of atherosclerosis, is the atherosclerotic burden. So the true target seems to be not so much ischemic causing stenosis, but rather the atherosclerotic burden, which is better controlled with good prevention, perhaps a prevention which must be better organized than we are doing now. I think it's a moving target. At the present, I think if you ask 10 cardiologists, 8 will tell, well, in this situation, better going for stenting. I believe that in 5 years, this attitude can change based also on new data, new trials we hopefully will have, and also based on the notion that the real enemy is the total burden of atherosclerosis, which we can counteract now more and more efficiently, bringing cholesterol LDL really down to 10, 20, 30 milligram per deciliter. Now we can tackle also LP little a, which was impossible before. We can address inflammation, which was impossible before with colchicine or new drugs. So I think that more and more will shift from a mechanical approach to a biological approach. But coming to your fascinating life, Ulrich, you started in Switzerland and then you continued in the UK. How was this transition? What are, in your opinion, strengths and limitations of these two systems?
Well, that's a very good question, of course. I was indeed intrigued by the long waiting period in the United Kingdom. It was, in my opinion, unacceptably long, especially for patients who did not have a private insurance. The NHS waiting lists were oftentimes 2 years for an intervention or coronary angiogram, and this was unacceptable in my opinion. But this has improved in the meantime. On the other hand, I was absolutely fascinated by the good personal communication we had among colleagues, excellent exchange of ideas, and yeah, talking about, for instance, the coronary interventions in hypertrophic cardiomyopathy. When I started looking at hypertrophic cardiomyopathy at the University of Lausanne, I thought about doing something in the first septal branch to decrease the thickness of the myocardium, but the ethics committee in Lausanne was absolutely incapable of giving a green light. And in London, when I came up with the same idea, the ethics committee, the chief of the ethics committee said, "Ulrich, that sounds absolutely logical. Why don't you go ahead and do it?" And they gave me the green light to do it. And so there was 10 years difference in two different countries, 10 years delay of a procedure which took over. There are now thousands and thousands of patients with hypertrophic cardiomyopathy who had this procedure done. And in Switzerland, it was impossible to get the green light for this. So this is one aspect between Switzerland and the UK. I don't know whether it is symptomatic or it's just an accident. But I much enjoyed my time in the United States, in the UK, in working in interventional cardiology.
Ulrich, now beyond stents, what are the main passions in your life?
I'm sorry, can you say this?
What are the main passions in your life beyond stents?
Oh, I see. Yes. Well, first of all, I have a family, and this is my daily pleasure to talk with the rest of the family. Then my wife and I created this foundation for children in need, called the Jonas Foundation, where we support children with music, dance, and drama in different countries, especially in Switzerland, in UK, and also Kyrgyzstan and Near East. And this helps the two of us enormously. I also enjoyed flying all my life and skiing until I had a hip replacement and a spine surgery, which made me giving up skiing recently. But these are the main features.
Very intense and fruitful life. Thank you for sharing with us. Colin, any last question or remark or comments?
Well, we do have some comments in the chat, Filippo, and I wonder if we should perhaps share some of these. Yeah,
please.
Yeah. I'll go ahead. So, Ulrich, we can discuss these together as clinicians. I don't know if you can see, but I'll take the first one from Dr. Tabatai. In the case of a patient with symptoms, there's a specific question about rosuvastatin. I suppose rosuvastatin might be considered a more potent statin than perhaps, for example, pravastatin or simvastatin. I think our colleague is asking about high dose and intensive statin therapy as a treatment paradigm for coronary disease.
Well, statins are absolutely necessary, I think. Which one should be the preferred one is difficult for me to say. I've been prescribing most of the time atorvastatin. If it is not effective, I ask one of my colleagues who is more into that to give a view on it. But I think cholesterol therapy is absolutely.
It's certainly an evidence-based statin. That's clear. There's another interesting question from our same colleague in relation to laser angioplasty. You must have experience of laser technology. Personally, I also do. At the Montreal Heart, we used the laser technique for very calcified lesions. Would you like to share any personal perspectives on laser angioplasty?
I'm afraid I'm not capable of giving some advice in laser technology. I think laser technology is very good for total occlusions, of course, and in order to reduce the amount of obstruction. But I'll stop there. I'm not in position.
It has limited availability, limited penetrance, but equally, where available in some centers, I know that it continues to be used and is felt to be helpful. I think these are probably the main questions that we've received in the chat. And I'd like to thank our colleague, Dr. Tabatai, for posing these questions. Filippo, I think I have no further specific questions at this time. I've thoroughly enjoyed the dialogue. It's been an enormous privilege to be with Professor Sigwart today. I might conclude with a passing comment that after this call, I will return to the catheter laboratory. I've stepped out. My list is being run by colleagues, and Professor Sigwart, I will walk in your footsteps in the rest of today as I go back to treat the remaining patients in my cath lab list.
Well, Ulrich, thank you again. You changed the history of cardiovascular medicine with your intuition. We use stents every day, and I agree with you. Stents are here to stay also in the future. Then we will have better and better medical treatments, but stents remain and will remain for a long time a cornerstone in the treatment of these patients. And the evolution of stents from first to second to third generation has been remarkable. And now the rate of restenosis is really acceptable, and I think that it is difficult to anticipate massive improvements in the future. While for medical treatment, the room for improvement is still very large, but with stents, really, every day we had remarkable satisfactions, and all this stems from you and from your intuition. I have a last question. I ask all our guests. The final question is, what are your suggestions for the future of our dialogues? Are you satisfied with our dialogue? Do you have suggestions to improve them in the future?
Well, it's very difficult to judge because this is the first time I'm taking part in such a dialogue, and I don't know how many are watching us.
Well, at the end will be more than 500 because our dialogues are posted in YouTube and what is now called X, this social media, and is posted and is typically viewed by hundreds and hundreds of colleagues.
You can reload it.
Yes, you can click in YouTube
and
X, and you you can view our dialogues. So our dialogues are typically, after posting them, viewed by hundreds and hundreds of colleagues. And I'm sure that this dialogue will generate a huge curiosity, because we all use stents every way, but I think for all cardiologists it's interest to listen to the perspective of our colleague Ulrich Sigwart, who first had the intuition of the importance of stenting. So this concludes our dialogue. Thank you, Ulrich, for accepting our invitation. Thank you, Colin, for sharing the responsibility of hosting Professor Sigwart. And as usual, the next dialogue will be on the last Thursday of the month. In May will be on the 29th. And our next guest is Charalambos Antoniades, another very innovative cardiologist who was born in Greece, and for many years now is a professor of cardiology in Oxford, with some innovative, again, innovation in cardiology is important, with innovative ways of predicting cardiovascular risk. So next dialogue, May 29 at 17 Central European Time with Charalambos Antoniades. I'm sure it would be, again, a very entertaining and useful dialogue. Ulrich and Colin, thank you very much again for this
Thank you
very,
for
very
inviting me.
hour. Bye-bye.
Bye-bye.